Hi, everybody. Welcome to today's student-led Journal Club seminar. My name is Anne-Marie Hayes. I'm a research associate for the Joplin campus of KCU. Today, I'm going to be introducing student Dr. Zach Taylor. Before I introduce him, though, I will mention student Dr. Taylor is presenting to us through NERV, which is a national neuroscience interest group. Specifically, NERV stands for Neurosurgery, Education, and Research Virtual Interest Group. They offer virtual opportunities for student doctors interested in specializing in neurosurgery and other neuro specialties. To learn more about NERV, you can click the link that I'm about to put in the chat, and we host a Canvas page for them that has more information as well as past presentations from NERV presenters. So now finally, to introduce our speaker, I will also mention that this link goes to the KCU intranet. So if you are not a KCU student, you won't be able to access this NERV page. But if you're a KCU student interested in NERV, feel free to click on this link. You can also email me and I can put you in contact with the NERV people and get you more info on that. So now to introduce our speaker, student Dr. Taylor is president of the Sigma Sigma Phi Student Osteopathic Medical Association and Neurosurgery Club, which they created at their school. They are the previous vice president of SGA at their school and is currently one of the head coaches of the Special Olympics in Kirksville. They are the director of service for IDD Club, and also they're a monthly author in the Helen Journal discussing various IDD topics. Today, he's going to be presenting to us about pressure on cerebrospinal fluid and blood. So yeah, take it away, student Dr. Taylor.
Thank you so much. So yeah, my name is Zach, and I am currently a second year, as she stated. This is the research I have been doing for the last year or so. I'm extremely interested in neurosurgery and the brain itself. I want to do trauma, hopefully one day down the road, a very, very long road. So we'll go ahead and get started here. Just a disclaimer, I had a huge exam yesterday, so I did not get to prepare as much as I would have liked to, but hopefully the fact that I've been doing this for about 390 days might help me a little bit. Okay, so the influence of venous blood on lumbar cerebrospinal fluid pressure, which I will call CSF from now on, just to be simple. So first of all, you might be wondering, why alligators? Alligators are the animal of choice for our research for multiple reasons. One being that they have pulsations in their CSF that we can actually monitor. And I took an intraoperative video of that I'll show you momentarily. And also alligators happen to have the same resting CSF pressure of about 4 millimeters of mercury, the same as humans. And these pulsations can be attributed to the ventilatory cycle, which these are lower frequency and higher amplitude, which I will show you in a second if that doesn't make sense. And then the pulsations from the cardiac side of things are attributed to the cardiac cycle at a higher frequency, but lower amplitude. So now let's make some sense of that really quick. And then I'll get to explaining what we're actually trying to figure out. This is a human model up here, and this is the alligator model up here. And then once I explain this, well, let me just go ahead and take a step back. So the reason that we are trying to figure out the resting CSF pressure and flow is that it's never been experienced before. No one's ever done any research along the lines of this. There was one paper published about 3 years ago stating that the cardiac pulsations are what drove CSF flow. So knowing the doctor that I'm presenting under Dr. Bruce Young, he is extremely interested and obsessed, I would almost say, with reptiles. And so whenever he read that paper, he immediately went to trying to use alligators. And as I was trying to explain that alligators are just like man in regards to the fact that their CSF will pulse with heart rate. But let's talk about this for just 1 second. So as you'll see, I said that these had lower amplitude but higher frequency. So this is frequency up here, and this is amplitude. And all this doesn't matter too much. I just wanted to prove to you that cardiac had the lower amplitude, and then ventilatory response had a higher amplitude. And so that paper was trying to say in 2019 that cardiac was the main driver of CSF pressure, but we have actually proven that ventilatory response is, while cardiac helps, ventilation is actually the main driver of CSF pressure. So now we'll take a look at this alligator model. This is our respiration curve. So intraoperatively, we intubate the alligator, which actually can be pretty scary because they actually have muscular control of their epiglottis. And so whenever we try to put the Mac blade into their throat to intubate them, they can actually punch it. And so it's about a 2-hour wrestling match trying to get that to go down their throat so where we can intubate them, because eventually they'll get tired enough, but their epiglottis will throw punches at you while you're trying to get down there. And it's very strong. So this is with our respirator added on. We have a full surgical suite, which I'll get to in just one second. And then this is our EKG. If any of you have ever worked in a hospital of some form, or if you're on rotations right now, we use the same COVID-in little EKG stickers like you do on a 12 lead, but we put them on the alligator. We have to use some ultrasound gel to cover it up in order for the monitor in order to penetrate through the alligator skin since it's so thick. And then this down here is the CSF pressure. So here we see that this is equivalating to the EKG strip here, but then once you see a breath taken in, you'll look down here, and then slowly, about 370 milliseconds later, you'll see a bigger pulse in that CSF pressure. And that has, what we have found out, has been linked to the fact that ventilation actually gives a stronger response to CSF pressure spikes than the EKG alone. And this is one of our alligators. We had 8 this year, so we do a full 14 to 18-hour surgery on each alligator. And I'll explain the whole entire surgical process in just one second, but I just kind of wanted to lay the foundation for what we're trying to approve and accomplish. And this has extreme clinical manifestations and clinical importance. 2 specific things. One is a Chiari malformation, whenever part of the cerebellum will actually protrude through your foramen magnum in your brain. And that can cause all kinds of symptoms like dizziness and issues with motor skills. And there's a certain surgery called a posterior fossa decompression that will cause, in about 25% of people that get this surgery, that will have a syringomelia, which is essentially just a fluid-filled herniation in the spinal cord, and that can be debilitating. And so we're trying to figure out why 25% of people, 1 out of every 4 patients that goes through this surgery, ends up with the syringomelia. And he thinks, Dr. Young thinks, that it's related to CSF pressure. And if we can somehow figure out if it's turbulent flow, and if we can figure out what the trajectory is, we can essentially find a different angle of posterior fossa decompression to where that CSF pressure will turbulate in such a way to where that syringomelia won't happen. So that's our clinical correlation. But now we'll get back into the nitty-gritty of why the alligator is so cool. So this right here, the alligators have a functional diaphragm, as I said. So they can go underwater for up to 5 hours, which allows us to do some form of apneic studies, which means to cut off the ventilation to where they are no longer breathing at all. Since they can hold their breath for 5 hours, it's not necessarily as inhumane as it would be for a human, because obviously we can't do invasive things like that to humans. And so, as we know, whenever we breathe in, we create a negative pressure in our intrathoracic cavity, which will then convey to large veins, and then those veins will dilate and will actually pull on the dura, which is the outer covering of the spinal cord, and will open up that spinal cord so where CSF can flow. And so now if you think about the fact that whenever we breathe in, as you saw in the figure, that the CSF pressure spikes more with ventilation, that just essentially means that we're opening up the spinal cord to allow flow. And then the cardiac-driven pulsations are thought to originate in the arterial pulsations in the brain, meaning that those arteries in the brain, whenever we have a heartbeat, that they're coming from the brain down to the spinal cord and causing a spike in the CSF pressure. So we are understanding that there are 2 separate aspects going into one complex pattern of how the CSF pressure spikes. And so as you might understand with how complex this is, that some of those breathing patterns will actually overlap, as what you'll see here. So as we'll take a look on the left here, this is our cranial CSF pressure. So I forgot to mention that, matter of fact, let me just go down here for 1 second, and I'm going to explain it through here. So this is our surgical suite here. We've got a ventilator and a machine down here with our intubation and whatnot. And then we also have a saline bag that we will fill in order to keep the blood volume from causing a drop in the pressure, which would affect our CSF. So we kept it equal by pulling out about 2.5 milliliters of CSF and then replacing it with fluid, so that way that the tube of the spinal cord would stay the same fluid or the same volume. So that way we're not changing any of our data points. So what we'll do is we'll wake up at about 6 a.m. and we'll go to the alligator humane room. We have this big zoo up on our 8th floor of our medical school that has a literal like sauna for these alligators, and it's exactly like a zoo. They have we have sprinklers and we have a heated, humid room. And so we have to kind of mirror that in our surgical suite. So if you'll look right there, that is a heater that keeps our surgical suite at exactly 98 degrees Fahrenheit. So as you can imagine, it's pretty terrible being in there for 14 hours. And so we all bring our big water bottles and hydrate because we sweat a lot. And so what we do is first we insert a pressure catheter into the brain around here so we can measure cranial CSF pressure. And then we'll keep that constant throughout the entire surgery. And so now in my part of the surgery, because Dr. Young puts that in, because that's a very, very particular way of doing it. And he's very experienced with 20 plus years of doing this. So I will do a laminectomy around L3 to L5. And laminectomy just means pulling out or shaving the pedicles on each side of the spinous process and then pulling it out to where we can see inside the spinal cord. So I will do that here. And after we intubate them, we give them isoflurane for anesthetic. So that way they don't feel any pain, but they are alive during the total operation. And then at the end, we euthanize them because we're poking on their spine and obviously their life wouldn't be as good as the way it is. So that's essentially what we do. So now I can go back up to here. So now that you know that we have a cranial monitor. So this is the cranial monitor here. And as you can see, if you look at the heartbeat, there's a heartbeat and then a spike that kind of matches up, and there's the little one and then another heartbeat spike. So now if you look at this heartbeat, it actually matches with the respiration. The respirations are the big ones. So sometimes they can kind of group together into one big blob, and they kind of makes these ugly looking spikes that don't look as clean as these, but the big spikes are matching up with the respiration. And so to kind of explain the words of the previous slide, this is just a simple cartoon stating that this little big green box right here is the brain. And so cardiac pulsations originate in the brain, and then they will travel down to the spinal cord. And then from the ventilation, that actually originates in the large veins, as I stated. So then those will go from the large veins to the small veins, and then the alligators and the specific species of alligator have a venous sinus that surrounds their spinal cord. And so that pressure gets put from there and then get into the venous sinus, and then that will kind of encompass the spinal cord. The humans do not have that, but as you'll learn in just a minute, the humans have something else that causes that constriction or some form of a block from spinal cord to brain, to where we can show you that CSF flow kind of goes into the brain and it has some trouble getting into the brain due to the foramen magnum and the epidural and the dural periosteal dura mater that attaches to the spine. But we'll explain that in just one second. I apologize. So here's a cross section of the venous sinus, or of the whole spinal cord of the alligator. And as you can see here, this is the spinal cord, and then this is the epidural space. Recall that in humans, the epidural space is filled with fat and blood vessels, but this epidural space is a venous sinus. So this is the venous sinus here, and it encompasses the entire spinal cord. And that is not like humans. So this is specific to the alligators. And and here's just an intraoperative picture that we took. So this is our laminectomy. This is about the L3 level. These are the pedicles here that we shaved off with a bone saw. And then as we gently pull off that laminectomy, because this venous sinus is so friable that even the littlest amount of pressure will rip that. So this is the venous sinus, and we can see that it surrounds the spinal cord. It goes down under here, and then this is the dura. The cool thing about alligator dura is that its pigment is black. It has a lot of melanosomes in it. So this pigment makes it look very, very unique. And so you can definitely tell whenever you're looking at venous sinus versus dura. This is not an alive alligator. This is just a model that we use because we had to practice about 5 or 6 times before we did the actual operation to make sure that our calculations were right and everything along those lines. So now here, this is just showing that the venous sinus is essentially 3 times the volume of the subdural space. So that will come into importance here in just a moment. So let's go ahead and then I just kind of explained that the laminectomy is the L3 or L4 area, and that's going to expose the venous sinus. So now let me show you this video. I told you that I'd show you this cardiac pulsation video. So now if you'll watch this with me, you'll notice that this is during an operation, and we recorded the spinal cord. So here's the spinal cord here, and the venous sinus has already been ripped. So you see that it's one of the coolest things I've ever seen. And if you've ever shadowed like neurosurgery or anything and you've seen the brain pulse, that's the exact same thing here. So I just think that is so cool.
I don't believe we're seeing the video.
Oh gosh, I'm so sorry. Let me see if I can.
You may need to switch screens.
Okay. Let me see here. Okay, so I will show the video at the end because I am gonna not be very good at doing this right now. I'm so sorry. I will show that at the end so that way I can talk through how to get that. But here's a picture of the video. It just won't, and maybe it will play here. Oh, there we go. Look at there. Okay. Okay. So here we go. Apologize for the volume. But here's the pulsation here. And then one more time. There we go. So that's the pulsation. So that equivalates to every time the alligator breathes in. We have them at about 5 breaths per minute. So that'll pulse around 5 minutes. That was pulsing a little more because I think that they were still in the middle of I think during that exact moment, they were wrestling with the alligator because it had kind of worn off of the anesthetic. So it was kind of growling at us, which is another scary story, but we can talk about that later. So after we do the venous sinus, or see the venous sinus, we're going to incise it. And then we will put some hemostatic powder in it to stop the bleeding, because as you can imagine, cutting a venous sinus that's filled with blood is going to be extremely bloody. So we have a suction tube set up into the spinal cord, and we can suction up the blood as we're packing in this surgical powder. And then we essentially make a ravine, sort of speak, that will surround the spot we're working on, so that way blood won't interfere with what we're doing. So we insert a pressure catheter into the actual dura mater so we can legitimately measure the cerebrospinal fluid pressure. So here is just a CT, which is another funny story. Imagine 2 people carrying an alligator that is about 7 feet long on a gurney all the way from our small city. So we will carry it from our operations suite down the elevator through our entire school, and our school is attached to a hospital. And then we'll travel through the doors, and then we have an alligator on this gurney. And so all the people in the hospital happen to see an alligator going through, and well, are we taking them to surgery? No, we're not. We're just taking them to CT scan. They're already in surgery, but they don't know that part. So we kind of cover it up with a towel for the most part, but people have seen its feet kind of falling off the bed sometimes, and it's hilarious to see their faces. So we put them in the CT scanner just to kind of show that you can see that the pedicles are gone. This one specifically, we did an L2 through L4. So, because we were kind of experimenting with if we need to do 3 laminectomies or 2 laminectomies to get the best surgical site. And so this was an L2 through L4 laminectomy. You can see that the transverse processes are still there, but the scales and stuff are gone because we had pulled the scales off in order to get there. So, and then this is the hole that we had to make with a power drill in order to get the pressure catheter into the brain. And here's just a picture of the pressure catheter. So we'll drill a hole, and it'll go down to about right here. And their brain is a lot smaller than ours. So you can see it, and you'll have to just go down until where you'll feel that the bone is no longer there. And so that's when you know you're deep enough. So then you can put the pressure catheter down into it. And then we just kind of super glue it here so that way it doesn't move, because we do various motions that I'll explain in a minute with the alligator to show different ways that we can manipulate the pressures. So ultimately, after we do that, we do multiple readings. So this is just a conglomeration of all of the readings we had at once. So this is the cranial CSF pressure here. disregard this part of it because this is a different study. So we're just looking at these 5 here. The cranial CSF pressure has multiple spikes due to the fact of the arterial pulsations from the cardiac as well as the ventilatory response. So you can see there's ventilation and there's ventilation, and then the cardiac make their own little peaks as well. And then this is the spinous venous pressure, and then this is the spinal CSF pressure. So we have a pressure catheter that read the venous sinus. We put a pressure catheter in the venous sinus, and we did a multitude of different manipulations where we would take the alligator, tilt it forward, tilt it backwards. We would wiggle the tail, just different movements to stimulate the alligator jumping or attacking or something to spike the CSF pressure. Because as we know in humans, when humans deadlift, let's say 400 pounds or something, their CSF pressure is usually around 4 to 5 or so. But then whenever they're in the middle of a deadlift, their CSF pressure can jump all the way to 120, 140. And so we're trying to stimulate things like that will cause the CSF spikes. And I know a lot of this doesn't make sense, but I can only show one slide at a time. So I will show you some slides of us doing the manipulations and how that affected our results. So this is just our venous pressure, and then this is our spinal CSF pressure. And as you'll notice, the spinal CSF pressure is actually higher up millimeters per mercury of mercury in regards to the spinal venous pressure, which is only about 1.2 or so. And that is because, as you recall, the spinal CSF, or the spinal cord, is about 1/3 the diameter of the venous pressure, or the venous sinus. So it's a little bit bigger, and so therefore the pressure it takes more pressure in order to spike. So, and we did this at the same 4 kilohertz sampling. That just gave us the most clear picture, and so that is the same for all of our data. And so now the cool part. So as I mentioned, you can put alligators in apnea we could do it for up to 5 hours and they would be fine, but we only did it for about 2 minutes at a time. So what we would do is we would allow it to run for about 30 seconds where we would just watch the screen and we'd watch it breathe in, breathe out. And then we would turn off the ventilator to where no more breath. And as you'll see, the EKG remains the same because the heart isn't affected by ventilation as much. It is a little bit, but not in only a 30-second time period. But now you'll see how the CSF was mixed, as I said, because it's a mixture of both. But then whenever we take out ventilation, you see that the cranial CSF actually drops significantly in pressure. And that's just showing that although EKG does help drive cranial CSF, it needs ventilation in order for us to get the biggest amount of CSF to our brain, and so on and so forth, keeping it inside of that tube and circulating. So I just think that's extremely cool. So we run it on apnea for 30 seconds, and then after the apneic study, we'll just turn the breathing back on, and then you'll see it slowly get back to this state. So now just imagine that the spine itself here is a tube with fluid in it, and then the venous sinus is a tube with fluid in it. So as you can imagine, the fluid inside can cause pressure on the spinal cord, obviously, because it's surrounding it, kind of like a hug. And although the humans don't have this venous sinus surrounding it, we still have other mechanisms that cause a little bit of pressure on our spinal cord, to where we will see that delay we saw, where if we go back up to here for 1 second, the delay of the breath versus, this is where I was looking for. So there's that 370 or so millisecond delay of breathing. And that's due to the fact that there's this looming pressure on the spinal cord that causes it to not flow as well as it could if that pressure wasn't there. So we're going to call that this pressure, but we know that it's the dura. And the dura is another compliant membrane that we peel out in order to put the pressure catheter in. So now let's analyze the cardiac CSF pulsations. So here's our EKG, and then there's our cranial pressure. And as you can see, looking at this line, I have the line put through the peak pressure of the cranial. And as you can see, it's not at the peak pressure of the spinal CSF. And that's exactly that's exactly due to what I just explained, with the fact that there's just a delay, because it has to get through that resistance in order for it to peak around the same time. If that makes sense, then we can move on to this part, where that just indicates essentially what I just said, that they're losing a lot of that propagation from the brain to the spinal cord due to that dura and the venous sinus surrounding that spinal cord. So the loss of energy will reduce the amplitude, which is what I showed you in a previous figure. and that will slow down the propagation velocity. So now I can finally explain some of those manipulations. So this figure here is normal horizontal alligator just laying on the surgical table. And this figure is us tilting the head down to 15 degrees. And we did that to try to see if we can maybe make the spinal cord have less blood surrounding it, because we tilt the head forward. So that means all the blood would pool towards the head, which would mean that there would cause an increase in the pressure surrounding the spinal cord. And that's exactly what is shown here. So this is horizontal, and you'll see that the cranial CSF pressure will spike up to about 2.5 millimeters of mercury, but the spinal CSF is only about 1.5. And so now, whenever we tilt it down to 15 degrees, you'll see that the cranial CSF is about the same, but the spinal CSF pressure actually fell below 1. And we can exactly demonstrate that that is because of all that pooled blood surrounding it and causing it to not be able to flow as well, which I think is just so fascinating. And so now we can analyze that same exact thing, except this time we're analyzing the ventilatory response. So here we have our normal CO2. So that's our inhalation and exhalation, inhalation, exhalation. And this is our heart rate. And these are those mixed ugly ones because both of them are contributing to make a cranial CSF spike. And then the spinal CSF spike is a little bit prettier. And then it kind of mirrors the venous spike because the venous is what drives part of the spinal CSF due to those big veins. That's where the ventilatory response comes. So whenever we're studying ventilation, you'll see an inhale, and then you'll see the spinal and the venous pressure spike, but you'll notice that the venous pressure is not as high as the spinal CSF, and that's due to the fact that the venous sinus is 3 times the diameter that the spinal cord is. So therefore, we can see that that the pulse will actually increase in amplitude as it transfers to the spinal cord, and that's just because of the fact that we need pressure, and that will equivalent to cross-sectional area. So with a less cross-sectional area and that same force being applied to it, it's going to be a bigger spike. And the post hoc analysis, I was trying to get him to explain this to me because he had just thrown this portion of that research into it like last minute. So I cannot explain what this is, but I can tell you that this will show up in a further slide that I can kind of help explain a little bit. So now with the ventilatory response, just like the cardiac, you'll see this yellow line in the middle of the spinal venous pressure, but then that delay, because the fact that the ventilation starts here, but then it has to travel through all the blood, and then it gets to the spinal CSF. So then you'll see the spinal CSF pressure spike a little bit later. And that's the same exact mechanism, the fact that it has to get through all this resistance. So there's a delay in 370 milliseconds, and then you'll see the main spinal CSF spike. So that's what we can kind of demonstrate is the dynamics. Sorry, looking at my monitor here for just 1 second. So the dynamics and stuff we can demonstrate with the several different studies. And so I only showed you the head tilting down on that slide, but you can also have, it's the exact same type of thing whenever we did tail wiggles, where we would grab the bottom of the tail and we would just wiggle them for 15 seconds and we would see a huge spike in CSF, but the other variables like respiration and heart rate stayed the same. So those pressure spikes will actually help us with another form of clinical correlation, and that's Alzheimer's disease. We all have been told that exercising reduces your chance of Alzheimer's, but no one has really kind of understood why. And we think that this is the answer. So whenever we studied the alligator with those pressure catheters in the CSF, we can actually see whenever we move the body in various different ways that spikes CSF pressure. And recall that Alzheimer's has those beta amyloid plaques that kind of build up in the brain, and then they cause you to lose your memory, and your brain just doesn't function as well because those plaques are kind of essentially clogging your brain. So whenever you exercise, your CSF pressure spikes, and that can actually cause those plaques to move. And so if you're constantly exercising, working out 30 minutes at least 3 times a week, you have a way better chance of not getting Alzheimer's because you're moving that CSF. And we think that this is the link. And so that's extraordinary to kind of find that out. But where does this influence end? Because as you'll recall, the alligator had the venous sinus, and that venous sinus actually ends at the foramen magnum, which is the bone that connects the spine to the brain, essentially. So that hole where the spinal cord goes through, and then it attaches to the brain, that's where the venous sinus ends. And so now I can explain the fact that humans have this periosteal attachment, which periosteal just means attaching to the bone. The dura will attach to the bone at that foramen magnum, but then it will stop. So that is the equivalent to the venous pressure. So the humans experience an increased pressure at that foramen magnum, which will cause the cranial CSF to not be able to leave as easily because there's that resistance. And the same type of idea with the venous pressure causing that collapsing pressure on the spinal cord, it's having trouble getting CSF from the brain to the spinal cord due to the fact that that pressure is surrounding the spinal cord. So it's not the same thing, but it's just kind of the same idea. So this, let me show you this once. There are wheels on the bottom of our surgical suite, and that looks kind of funny because they're kind of on a skateboard, but really we use those to do push-pulls. So now the alligator's anesthetized and they're on that little table. And so we're gonna pull the alligator back towards us. And whenever we do that, we see an increase in the pressure. And that's because it will follow. So whenever you pull towards you, the CSF will actually accumulate on the other side, just like with the simple laws of inertia, that whenever you pull linearly, the fluid that's in the tube is going to stay on the other side because it's attached to that wall because it doesn't know what to do with that pressure. So whenever we pull it really hard, that pressure will actually go towards the brain. And then whenever we stop it abruptly, it will mirror the exact peak and it will go down, and then you'll see that the CSF goes back towards the operator that's pulling. So that's just showing the simple mechanism of inertia, that whenever we pull, the CSF will go away from us, but then when we abruptly stop, that CSF, as it's in a tube, will now flow to the other side and will then go back to baseline. And then we just have a normal peak like nothing happened. And so that manipulation was just showing that actually it's so easy for the CSF to get into the brain whenever we pull it really hard. And so that is kind of shown on this mathematical graph. But there's something interesting. Whenever we pull backwards, there was only a 0.6% increase. And by increase, I mean this down here is your spinal pressure, and this here is cranial pressure. So it only did 0.6 units of cranial pressure change whenever we pulled the alligator backwards. But whenever we pushed the alligator forward, it had 2.21 times of units per cranial. So therefore, 1 unit of spinal equals 2.5 or 2.2 units of cranial pressure. So whenever we push the alligator forward, it actually causes more fluid to go in to the spinal cord. And that is just shown here whenever we did an MRI, and we did these under the MRI machine, and we watched the fluid propagate. And it was 4 times, because 2.2 divided by 0.6 is like 3.67 or something, but close enough to 4. So it's 4 times easier for the CSF to flow rostrally, aka towards the head, than it is for it to flow caudally, aka back through that hole. This is the foramen magnum here, back into the spinal cord. And so that all of that just to say that this is proving that there is that little tiny spot in the alligator where the venous sinus stops. So it's very easy for CSF to flow into the brain because there's no longer that barrier. But whenever we're trying to get the fluid to go back into the spinal cord, boom, there's this venous sinus there that's stopping the propagation for its full potential. And so this is a human here. So here's the foramen magnum, and this is the periosteal dura. And as you see, it's attached to the bone there, but now there's no more bone, and that periosteal dura does not continue. So therefore, the resistance would be here, but there's no longer the resistance. So whenever we push it forward, it can get through that hole. But then whenever we try to pull it back, it's just like a bunch of people at Walmart trying to get to one aisle. They just can't all get out that easily. So, and then here's your C1 here. So that's just showing that that's your first cranial vertebrae here. And then there's a bunch of anatomy that I need to review, honestly, for boards. So now just kind of retouching on what I said earlier about the Chiari malformation, was that this asymmetry of the CSF, the foramen magnum, could potentially be altered with a posterior fossa decompression if we can somehow find a surgical way or some form of a model. We are essentially trying to transition our data that we're extrapolating and creating all these graphs, and we're going to transition that into cadaver model. And our cadavers, we can fill up with the CSF, and we can try, I think he's trying to do operations on the cadavers to see kind of just what happens with the flow. I'm not too understanding of exactly what he's trying to accomplish with that point, because I will be at rotations, so I won't be able to continue this portion of it. But his essential, what he's trying to accomplish is to maybe figure out a different approach to posterior fossa decompression. And then also, just to further reiterate the fact that Alzheimer's, we might have found the link to the fact that whenever we move our body, it's just getting that CSF pressure to flow, or not to flow, but the increase in CSF pressure will cause those beta amyloid plaques to dissipate and to flow out and not coagulate in the brain. And so I know that was a lot of information to swallow, but that was the end of my presentation. And I was a little shorter than 30 minutes, I'm sure. Maybe not, I don't remember what time we started, but I am going to attempt to answer your questions. And if anybody has any.
Zach, I have a couple.
Okay.
First of all, it's very obvious that you are enthusiastic about this, and it's palpable, and you do a very, very good job at energizing us in this area. So I'm not as fluent or as comfortable with all the pressures as you are, but I focus on the clinical corollary. And again, where would be the emphasis on decreasing the amyloid or whatever the tau markers are associated with Alzheimer's? Where would be that emphasis to decrease that progression to eventual Alzheimer's disease? Where would you focus?
As far as you mean focus like with exercise and how to tell people what? Sorry.
But what else can you do other than to? Yes, exercise does. Let's say increase the heart rate, may increase the O2, may decrease some PCO2. What else is it doing in the brain to have some clinical relevance?
That's a good question. I'm not exactly sure how to answer that. I apologize, but
no apology at all. If that's what I'm trying to get at, is the corollary and the take-home message on a clinical. I think all physicians are going to say, make every attempt to get out and exercise, etc. I just didn't know if it's been explained by what you just presented to us, how that does correlate to slowing the progression in the management of Alzheimer's.
I see what you're saying. Okay. So I do know that he was mentioning a paper that stated that was kind of proving that exercise does in fact help. And I'm thinking to maybe hopefully answer your question would be, I think what happens is just any form of motion. I know exercise is kind of the biggest thing, but we even saw there was a study that someone had gotten into a car accident and had such stress and increased with squeezing for bracing that their CSF pressure was like really elevated when they got to the hospital or something like that. And I think I'm kind of running in circles here, but I can't specifically answer your question, so I'm sorry, but
No, that's okay.
I
Don't
just-
worry about it. I'll yield to Dr. Carilla, then I'd like to have come back and ask you another question. Go ahead,
Sure.
Carol.
Thank you, Dr. J. Again, Zach, he's absolutely spot on. You're incredibly motivated and enthusiastic, and I applaud your willingness to work with these magnificent animals. Even after they're anesthetized, it seems a bit challenged. But anyway, my thought in response rather to Dr. Johnston's question was that anything that increases the circulatory flow would increase the and we haven't necessarily identified what leads to the amyloid and the tau proteins and all that, but that the increased circulation that's generated by that increased exercise or any movement, like you said, would then thereby carry off and continue the circulatory flow of byproducts and metabolites and anything else that might potentially deposit in the brain to form those. So, and I know that Dr. J had another question, but thank you so much for your detailed presentation.
I appreciate
Absolutely.
that. I think Dr. Steininger may have a question.
I had a comment and perhaps a question, and I'd like you to comment on an observation. First of all, yeah, they're right. Your enthusiasm is palpable. I sense it. And I think your project is a perfect example of how basic science could potentially inform clinical science. The immediate application of studying CSF pressure in alligators may not be obvious to folks, but that's why you do the experiment. You never know what's going to come out of it. And so I have a question for you. Is this done at ATSU in Kirksville?
Yes, sir. We are on our zoo, if you want to call it, is on the 8th floor, but then our surgical suite is on the 7th floor. So we're doing all of this at our school. Yes, sir.
So what I'd like to do is just commend ATSU for supporting basic research endeavors at your DO school, and you for delving in so eagerly. And let me ask you a question. Does this put you on a path to becoming a clinician scientist after you graduate and when you grow up and stuff?
I have full intention to at least do a research year, if not maybe pursue a PhD. So yes, I just love science, and I'm definitely going to put this into my practice. One, because it's a funny story to tell patients, but also I just love the fact that we can just study different biologies, different animals, and all see different things, but somehow we can all link us together with, the fact that they have the same resting CSF pressure as us. And yes, I do think that that's going to lead me to being a clinician as well as a scientist.
Again, it's a tribute to your institution and a tribute to you for engaging. Thank you so much for your presentation.
Absolutely.
Zach, my follow-up is on your last slide, or a slide right here, how a surgeon would go about approaching a posterior fossa area for decompression surgery. You mentioned that it would alter their approach. Can you tell me how that would be affected?
So I obviously I've never actually seen this surgery done, but from my understanding, I believe that you could maybe change the intraoperative angle. I do not know exactly how they shave off the posterior fossa, but I think if he's essentially trying to explore the idea of maybe hitting it at different, so instead of, I'm pretty sure that with posterior fossa decompression, it's just straight up, just straight down the middle. But if you can somehow tune the angle of which you're approaching it, then that can somehow cause the turbulence to flow down more the tube versus it, or maybe making it more non-turbulent by the fact that we're angling it at a certain, I do not know the angle.
No, that's fair. That's okay.
But just causing more fluid flow versus more turbulent flow, because we're thinking that the turbulent flow is what causes it. It's just constant pressure with the fact that the angle, and then with the CSF going down, that it somehow can push on one of those weak spots of the dura, causing it to kind of protrude. But if we can somehow study the mechanics of the pressures and how they increase after the operation and things along those lines, noticing where the trajectory is headed to where the syringomelia occurs, maybe somehow tuning it to where we can maybe make it even go down further and it protrude at C3, maybe down to C5, and eventually get it to the point where it's pointing down straight and flowing through the tube as just the tube versus like the walls.
Yeah.
It's
Okay.
essentially, it's kind of what I'm explaining or understanding.
You know, I can picture this in terms of there's a lot of precautions that you folks have to take just to get everything going in a position that you can measure pressures and in a safe manner. I'm going to ask a very naive question on this, but who has that responsibility to intubate that alligator?
Yeah, so our statement that we had to sign essentially says that we are not allowed to touch the animal in regards to it being awake. So
I would think so.
yeah, so he isn't completely in charge from about 6 to 8 a.m. So whenever we go upstairs, he really does use like a noose, like you see whenever you try to catch a stray tiger or something like that. They use that noose and then pull it around the neck. So he will go inside the area and then he'll shut the fence so it can't escape. And then he will just one-on-one wrestle this alligator and put it around the neck, and then he will hug it and he will roll around with it because they like to do the death roll. And so they do that all the time on him. So you just see them flopping around in the mud, and then he'll eventually hug it because they weigh about 105 or so pounds. So he can eventually get it up, and then he has a helper that also can touch animals. So they two go together and we'll pick it up and put it on a table, and then we strap it down. So we'll strap it behind the eyes, and then we'll strap it like mid back, and then we'll strap the tail twice because that tail can throw me across the room. So, and it's awake and it's extremely angry while we're driving it. And they like to hiss, kind of like cats, except way louder. It will actually make you cover your ears if they growl at you. And so that's essentially what happens. And so I have a picture, I think, here. So this little bite block right here, we will make it open its mouth by taunting it. And then we will put the black bar into it. It's like metal, and it has a little bit of safety cushion around it, so that way it doesn't hurt their teeth. But then they'll clamp down, and then he quickly tapes it, kind of like a cattle wrangler, and we'll tape it. And then they only have about 2 pounds of pressure able to open their jaws. So if you can hold it, like I could hold it with my 2 fingers, and they could not open their mouth against my resistance because they just have no musculature for that. But their bite force is, I mean, I don't know, unmeasurable. So then they tighten that, and then from that point, he can no longer bite down. And then he'll take the Mac blade and he'll turn it sideways, and then he'll wrestle that epiglottis because, like I said, they have full control over their epiglottis and can literally punch the Mac out of their hands. And it's not funny necessarily, but he starts cussing and getting all angry at it because it will not stop punching the Mac out. So you have to really be strong. But then once you get it intubated, it takes them about 2 hours for the anesthesia to kick in, and then they're gone. And sometimes we have it on a constant drip. So sometimes it can kind of wear off, and then they'll start growling with expirations. And that's kind of our indicator that they're waking up. So we'll stop operation until we give it some more isoflurane. But those growls are really scary, especially whenever you're in the middle of an incision.
How long can you leave an alligator under anesthesia and continue to do what you do?
The longest with 1 tube of isoflurane is about 6 hours. So we go through about 2.5 bottles of isoflurane, and that will hold us for about the 14 hours. And so another thing that's kind of cool about alligators is that they're actually still alive after they die. And I know that doesn't make much sense, but whenever we're done with the surgery, we will take it off the table after it's wearing off from the anesthesia, but he's still taped. And then we'll take the heart out really quickly, but it can stay alive for up to 4 hours after that. So one of his buddies actually lost a finger because he didn't know that they stayed awake or stayed alive after we took the heart out. So they'll still crawl around the room. So we have to keep it tied down until we wait that time period. Wow. And so, because he uses the alligator to study all kinds of stuff. He does like their paw prints, and he'll study their esophagus because their esophagus can actually still swallow. So if you put your finger in their esophagus after they're they're passed away, it'll still try to swallow your finger 4 hours after it's been, there's not even any blood in the alligator. So it's insane.
Zach, I've enjoyed your presentation. You're one brave person to do this, and thank you for sharing what you've done. Thank you.
Absolutely. Thank you.
Yeah, just to reiterate, thank you so much for presenting the Journal Club. Your passion to learn and passion for this project definitely made for a super engaging presentation, but it also made me really grateful to be a tech in a lab that works with cells and tissue culture and maybe not alligators. But thank you again for presenting, and thank you everybody who joined us today for the Journal Club. Great job.
Thank you.